Hello, everyone. This is Kathy Bush, and welcome to the DandleLION Medical webinar titled Building Moral Resiliency, the Nurse Education and Support Team. Our faculty presenter this morning is Dr. Michele DeGrazia. Since joining Boston Children's Hospital in 2005, Dr. DeGrazia has played a number of key roles across the institution. In the NICU, she maintains an active clinical practice as a neonatal nurse practitioner and serves as the unit-based director of nursing research. Within the Department of Cardiovascular Critical Care Services, she serves as the Nurse Education and Support Team, or the acronym NEST, lead. This innovative team concept engages nurses encountering morally and ethically challenging situations to provide just-in-time support with the focus of promoting a morally resilient workforce. At the institutional level, Dr. DeGrazia serves as the co-chair for the Nurse Executive Committee for Research and Inquiry and chair for the Nursing Research Council. Both provide support and oversight for nursing clinical inquiry. In her role as an executive producer for Open Pediatrics, she also facilitates best practices in pediatric care through the Nursing World Shared Practice Forum. And finally, her faculty appointment is Assistant Professor of Pediatrics at the Harvard Medical School. Welcome, Michele, and thank you so much for being our faculty member this morning.
Thank you, Kathy. And can you both hear me okay? I just want to confirm.
Yep.
So hello and happy Thursday to everybody. I want to take a minute before I start to thank the two Kathys, Kathy Randall and Kathy Bush, for inviting me today to present my work on the Nurse Education and Support Team. This project is a team effort for sure, and would not be possible without the vision and support of my supervisor, Dr. Patricia Hickey. In terms of this presentation, I have nothing to disclose. And to provide a little context, before I talk about the Nurse Education and Support Team, I just wanted to tell you a little bit about Boston Children's Hospital. It's a large urban quaternary care freestanding children's hospital in the Northeast. It is magnet designated since 2008. And we have 4 intensive care units and several cardiac specialty units. One of the cardiac specialty units is covered by the NEST team. They have a lot of complicated medical and surgical patients. And their unit really could be defined as a progressive care unit. Now, I don't think I need to tell the audience that critical nurses of today have lots of challenges. The increased complexity of care we're seeing is really just, growing by leaps and bounds. The regulatory burdens we are encountering are something that we are constantly working to overcome. We are constantly trying to balance effectiveness and efficiency, and sometimes we have to deal with unhealthy work environments. One of the issues that has developed over the years is this concept of moral distress, and that is something we've seen a lot of articles about in nursing, particularly over the last couple years, and especially during the COVID-19 pandemic. At Boston Children's, moral distress really came to light through 3 nurse-led research studies that informed our understanding of this issue within our acute and critical care units. The 3 studies were led by these nurses that are now on your screen: Melissa Burton, Brianne Leary, and Maureen Hillier. And all of them shed light on the issue of moral distress, particularly, of course, Melissa Burton's, whose focus was on moral distress in the pediatric ICUs. And what Melissa found was that this was an issue that our nurses were frequently encountering. And we had really widespread interest and participation in the focus group she held on that particular topic. In terms of moral distress, by definition, though there are many out there, The one that I tend to go to is the one by the American Association of Critical Care Nurses, where moral distress is said to arise from the inaction in the face of an ethical question or conflict that compromises both personal and professional values. Now I'd like to talk a little bit about the concept of moral resilience. This is another concept that has gained recognition and is deserving of consideration. Moral resilience is said to transform profound despair and powerlessness into opportunity. It supports having an ethically clear and coherent voice that can be heard, understood, and that enables action. Moral resilience allows clinicians to speak with confidence and clarity about overt threats to their integrity. And in terms of moral distress can actually serve as a catalyst for moral resilience and for moral progress in nursing. So although we don't think moral distress will go away, it can certainly be a positive, as I said, catalyst for moving towards moral resilience. Now I'd like to talk a little bit about the implementation of the nurse education and support team and how it came about. As I explained, there were these 3 nurse-led research studies, and they shed light on the fact that we had nurses experiencing moral distress, and we wanted to be able to offer them something. So we were charged by our leadership to begin with development of a focused group of professionals, work group, if you will, to really dig into this moral distress concept and learn about it and come up with a plan of action. The plan was for us to make recommendations to the leadership on ways that we felt could help address this issue within our cardiovascular and critical care settings. When we met, we realized that although there were experts in the field across the world on moral distress, there was no blueprint available for addressing this problem. So our work group, which consisted of representation from ethics, nursing, chaplaincy, social work, and others across the institution, we worked together and came up with some recommendations that we felt could be implemented within our kind of fast-paced working environment. We recognized that existing support structures that were in place at the time and resources did not sufficiently meet the needs of our nursing staff. And we sought to safeguard our clinical staff through a framework of high reliability and a healthy work environment. So we embarked on this journey, shifting from distress to resilience. And as I said, we had a couple of frameworks actually that supported this work. The AACN's Healthy Work Environment, of course, was served as a perfect framework for this work, as well as the IHI Joy in the Workplace. So in all of our meetings and throughout our meetings, we continue to kind of hone in on what could we offer nurses beyond what was already being offered in the institution. And we had a lot of things in place. We had wellness workshops, we have Office for Clinician Support, we had the Employee Assistance Program. So there were and are resources that continue to be available to the nurses. But really at the direction of Dr. Hickey, she really felt like we could offer something more, some just-in-time support. And the vision of herself and the work group collectively, we decided that while caring for these complex patients, what nurses really needed was this just-in-time support. We didn't want our nurses to have to wait, 2 weeks or even sometimes 2 months to get an appointment for the Office for Clinician Support to talk about an issue that might be, actively going on within the unit. We recognize that critical care bedside nurses possess the knowledge and skills necessary to support their colleagues in these morally and ethically challenging situations. And we knew that although the nurses, were already supporting each other, perhaps maybe it wasn't as efficient as it could be. We also understood that nurses could build moral sturdiness and emotional resiliency through education and support within their own profession. So this developed into a role that was put forth and recommended by the working group, and was really, a vision by Dr. Hickey. And it consisted of highly experienced nurses who could support their colleagues, identify and navigate morally and ethically challenging issues. And in this picture is 6 of the nest coaches that are, presently functioning in that role. The qualifications of the coaches, we knew we need to develop some qualifications of what this team would bring, or, who would be stepping into these roles. And we went to leadership and worked with them to develop a list of what we believe would be fitting for these individuals. Things like past demonstration of leadership qualities, strong interpersonal and teamwork skills. They needed to be somebody that was vested and interested in the topic, as well as somebody that was respected in the unit and that would be non-judgmental, a good listener, and so forth. We also knew that we would need to prepare these individuals for this new type of role that they would be encountering. Now, these are critical care nurses, trained, highly skilled, but never had stepped into this kind of role before. And as I said, there was no blueprint. So we needed to develop some resources and education to prepare them for this new role they were going to undertake. We had them participate in selective conferences, seminars, and shadowing experiences. For instance, we had them attend the Compassion in Care Conference, Death and Dying Workshop. We had them round with our ethics team. We had them round with the palliative care team. So they were given a really wide range of different types of experiences to help prepare them for this new role. In January of 2017, we rolled out the nest coach role. We began with a day-long retreat where we held some educational sessions and some opportunities for them to have some open discussions amongst themselves and get to know each other, because these were individuals that hadn't been necessarily working together prior to this time. So during the retreat, we were able to bring in the ethics team, as well as other specialists across the institution, communication specialists, for instance, to help inform them and prepare them for the role, in addition to the training they had received. Then on January 9th, 2017, we rolled out the nest coach role, and the nest coaches began rounding on the units and meeting with staff and educating them about the new role. In addition, we had the nest coaches go to the staff meetings and also do presentations to educate staff about this new role that was going to be present and available to them. So the nest coach consultation and support, we had to decide on how we would operationalize this across the units. So what we came up with was having bedside consultations and preset office hours 5 days a week, 8 hours a day. The nest coaches could be reached by phone or email, and the primary function would be for them to support the nurses through morally and ethically challenging situations. Our consults are kept confidential and anonymous in our documentation, because we want the nurses to know that the information they share with the nest coaches is private and will not be shared beyond that conversation. And our nest coaches also refer nurses to appropriate resources if needed beyond that kind of initial consultation. So perhaps a nest coach is consulting with somebody and recognizes they really could use or benefit from speaking with somebody from the Office of Clinician Support. They would help make a referral to that individual to the Office of Clinician Support to ensure that that nurse gets follow-up and an ability to resolve whatever issues they might be encountering. Here on the screen is a figure demonstrating what the nest coach role looks like daily. So the nest coaches come in to the office and they review sign out from the previous nest coach. So they do leave a sign out identifying hotspots within the different units that the nest coaches should, follow up on. Also, they might leave names of individuals who have asked for the nest coach to come by and check in on them. They round on the units, they encounter consultations, and they provide staff support. They also do some education series on different topics that might be of interest to our nursing staff as it relates to moral and ethical challenges. From January 2017 through August 2020, when we ran our last statistics, we had over 8,000 consultations. And the consultations span all of the ICUs and the cardiac step-down unit pretty evenly across the units. I think our NICU in particular is a difficult unit because we are still an open bay format. So having private conversations can be a little challenging in that situation. But soon, my understanding is we're going to be having a new building with a brand new NICU. So hopefully there will be more space for those consultations to occur. In terms of the method of referral to the nest coach, most nurses refer themselves. So they may see a nest coach rounding in their unit and they approach the nest coach to have a conversation. Sometimes another staff RN or charge nurse might refer a nurse to the nest coach. Most of the individuals that are benefiting from the nest coach are those bedside nurses. However, there are other individuals through the years that have been acquired and been supported by our nest coaches. We've had respiratory therapists, physicians, administrative assistants. When we took on this role, we decided that although our focus would be the bedside nurse, if there was another individual that was seeking our help or support, that we would not obviously turn that person away. In terms of the nature of the nest coach consultations, we kind of put them in two buckets, if you will. One, individual based, where moral distress occurs when the nurse is conflicted about care-related decisions and ability to be the moral agent for the patient or the family. And those are the patient based. Which moral distress occurs when a team and parent barriers prevent the nurse from providing care compatible with his or her own personal values and beliefs. It's interesting when these statistics were done, they were done at a time where we were kind of experiencing COVID-19 stressors. And we did an analysis looking at the 3 months prior to the onset of COVID and the 3 months following. And during that time frame, we saw a really large increase in the number of individual-based consultations where nurses wanted to talk about their own conflicts and worries. That was an interesting finding and just really spoke to the importance of having somebody available to talk to during those types of crises. In terms of the breakdown of the nature of individual-based consultations, we see that work-life separation really stands out as an issue for our nurses. And other issues, of course, that nurses encounter are, things like communication and transparency, role conflict, as well as grieving staff. In terms of the patient care-based consults, the ones that kind of really rise to the top are those challenging patient situations, difficult family situations, or futility and poor prognosis. So we see that nurses really struggle with these issues, and having somebody to talk to and think through things with can be really instrumental. In terms of the length of the Nest Coach consults, we tend to see that they are, usually in the vicinity of 15 minutes or 15 to 30 minutes. Over the time of the onset of the COVID-19 crisis, if you will, we saw the length of the consults increase, where our Nest coaches were spending more time talking with staff about their individual concerns and worries. Most of the Nest Coach consults do not require follow-up, however, a few do. And as you can see down below, the types of referrals that have been made, sometimes it's to their director or manager, the employee access program, self-care seminars, chaplaincy, and ethics. At about 6 months and 1.5 years, and then again 2.5 years following implementation of the Nest Coach team, we did an electronic survey evaluation, and we wanted to see how staff were feeling about the Nest Coach team. Our questions consisted of yes, no, and multiple choice, as well as Likert scale type answers. We also allowed nurses to provide some open-ended comments and feedback and suggestions about the Nest Coach team. And here is our survey results. So here you can see the nurses were surveyed in 2017, 2018, and then 2020. We had about 100 nurses respond to each of the surveys. That's about 20% of our staff across the units that we were covering. In terms of the respondents, most of them were direct care bedside nurses. We had a few nurse practitioners and some other various professionals that responded to the survey. We had respondents from all of the units. As well as, in the most recent year, we had a couple respond from our float pool. We have nurses working in our ICUs from the float pool, and they have actually reached out to me and indicated that they have appreciated having the Nest coaches available when they're working in our units. In terms of years in position, we've had nurses who are in, the first year of working in the unit to those nurses that have been working for more than 20 years. So we've had a wide dispersion of responses in terms of years in their position. In terms of, we wanted to know how we were doing in relation to educating them about the Nest Coach team and making sure that nurses were aware of the role. So when we surveyed them, we learned that, it has been an increasing awareness of the role over the years that we've had it. So we've seen a steady increase in awareness, which we were very pleased about. After the first couple surveys, we teamed up and went out and did some more education about the role to make certain that people knew that it was available. In terms of interacting with the Nest Coach role, or Nest coaches, I should say, we've had increased interaction through the years. I think that speaks to people feeling more confident and comfortable speaking with the Nest coaches. They've gotten to know them. They know that these conversations are private and that they're not shared beyond that conversation. And it was nice to see an increased rise of interactions through the years. We looked at reasons for no interaction, and some people just don't feel they need to interact with the Nest coach, and we knew that would be the case, and certainly that's fine. People have sometimes their own support systems in place, and they feel comfortable and no need. We also asked them what prompted them to interact with the nest coach. And for the most part, it was the nest coach being on rounds in the unit. So they saw the nest coach and they then interacted with them, which is great because we knew that by this response that this model was working in terms of that just-in-time support. And then we also asked them the ideal way to access the nest coach. Most nest coaches indicated that they felt, most nurses indicated that the nest coaches during rounds was the best way to interact with them. And again, supporting that, how we were operationalizing this role. In terms of impact, as you can see here, going down on the slide, we have the years 2017, 18, and 20. Just to orient you to how the slide is put together. We asked them if they were satisfied with their interactions, and we can see that greater than 80% across the board in all 3 years that they were surveyed, that they were satisfied with the role. They also indicated that the nest coach was helpful, easy to contact, was available to meet with them at a time that worked with their schedule, that the nest coach addressed the issues that were important to them, and that they would use the nest coach services again. And I think that this, speaks to the fact that nurses really embrace this role. They found the nest coaches were helpful, and I think they, in generally look forward to seeing these nest coaches come through the units, and it's somebody to talk to that has walked in their shoes before, understands the issues that they're dealing with, and is able to help them, come up with a plan for addressing the issues. So in summary, to support our nurses through morally and ethically challenging situations, we recognize the need for this innovative approach. The Nest Coach Team is a novel program and a new role that was established responding to the AACN's Healthy Work Environment and IHI's Join the Workplace. And successful implementation of this role has demonstrated it is both feasible and impactful for our nurses. Just an acknowledgement of all the individuals. As I said when I started this talk, that this has been a team effort. Lots of individuals have been involved in this this project and the success of the Nest Coach role. So I've gotten through my slides a little more quickly than I anticipated, but I'm happy to have questions and conversation with all of you to answer any questions that you might have.
Michele, thank you so much. That's, what a real wonderful program to be able to offer your staff. I can see why it's so popular, and I'm sure the staff really feel appreciated and understood by having something like this. And it's really exciting. So we would love to open up to questions. If you will type your questions down in the Q&A button down at the bottom of your Zoom screen. Kathy Randall is also here with us, and she will be the one reading the questions and kind of reading them out loud. So Michele will be able to answer them, and then people can hear the questions and answers when they're listening to the recording. So please feel free to type again.
Yeah, and if anybody wants to have me unmute you, just raise your hand on the participants channel. That's sometimes a little bit easier, especially for a conversation like this, where I feel like the dialogue is almost more important than the question itself. So if you want to, raise your hand, please do that. I see, Sandra, you have your hand up, but I'm going to lower that just in case that was an accident. But go ahead. It looks like they're, so one question came in already, which was, were the coaches already working in other roles on those units?
Oh, yes, thank you. That's an excellent question. Our nest coaches are all critical care nurses. We identified one nest coach per unit. Actually, one of the units decided to put forth 2 individuals for the nest coach role, so they share in the, so you think about it, we have 5 days a week we're covering. We have 6 nest coaches. So most nest coaches do 1 shift per week, and the rest of the time they're working in the unit as a critical care nurse in their respective unit. Kathy, you're on mute.
Yep, sorry. Was the nest staff available to weekend and night shift staff?
Yes. So when we first started the role, we didn't have the bandwidth to cover all shifts, but in the sense of what you would think in terms of like 7 to 7 shifts. But because we didn't have the bandwidth to do a nest coach per shift, we actually, the role they cover 1 to 9:30 is their shift. So they will come in, they'll work in their units either before or after their nest coach shift on various, projects or perhaps helping within the unit. And then when they start their shift, they work from 1 to 9:30. We do have one individual that covers just nights for the nest coach role. So once a week, we have somebody at night covering.
Awesome. Pretty obvious question, but I think an important one, because I think all of us would want to know this, is how do you start this up at other hospitals? What would be someone's first step? Thank you, Candace, for asking that, because I think that's what everybody wants to know, right? This is awesome. How do we start?
Right. So we actually, were fortunate that we had the support of our administrative leadership. I think that is key to the success of this role. Often people ask us, how did you get the financial, means to do this? And this role was not in addition, like there was no extra FTE that was obtained, that each of the units put forth a small percentage of an FTE to make the 1 FTE that we have that covers the nest coach role. And I think the other thing that was essential and instrumental to the success of this was the work group. Establishing a work group to come up with a plan and vision for how to operationalize this in your setting. We're going to be publishing this next month in the American Journal of Critical Care, and that provides a great deal of detail. That publication will provide a great deal of detail on how we operationalize this role, and it would be something you could also, I think, bring to administration and support of developing this type of role in your own facility.
Yeah. So here's a question. It's a great question from Kim about, would you or others within your NEST program mentor other institutions as they begin to want to take this on? It's not quite published yet. Now we're doing the webinar, so everyone knows it's there. All the thousands of people on the DandleLION webinar are going to be finding you and saying, how can you help us? So have you guys thought about that? How will you translate this to another institution, and what support maybe would your hospital be providing, or would that be something that you guys might think about now?
Yeah, I think we could think about it. We haven't, we really, because this was so new, and we didn't know honestly how it was going to go when we started it. We didn't know if it would be, enculturized, if you will, into the unit, if people would embrace the role, if they would utilize the role. So we really kept it very much kind of contained in the early days. I have met with different teams at different institutions for, just kind of group conferences to discuss ways that perhaps they could start and think about implementing in their facility. I'm happy to share that information with folks. And like I said, I think having it in the publication is going to be really helpful to people, because they can read about it, exactly what we did to get this going.
Excellent, excellent. There was actually 2 questions, very kind of related, which was, who provides the moral support to the NEST coaches? What support is there when they're feeling overwhelmed or stressed or dealing with multiple difficult situations?
Yeah, so this was something, fortunately, we anticipated happening. I think it is quite eye-opening when you are kind of more broadly seeing what's going on across all units versus, I mean, any one of the ICUs can be really, difficult and challenging. And but when then you see that kind of multiplied across,
Right.
several units, we knew that, and also the weight of carrying the weight of somebody else's stress can be difficult. So what we did when we first rolled out the nest coach role, for the first 2 years, we had a social worker who was actually part of our original work group, help support our nest coaches. And he would meet with them on a monthly basis and have conversations with them individually to see how they were doing in the role, to help support them. Now they all kind of support each other because they've been doing it for a while. They're kind of used to the experience, I guess, if you will, of being a nest coach.
Awesome. Awesome. Two related questions kind of from Anne and Amanda. So could you give some specific examples of issues that have been brought to the nest and how that was resolved? And then maybe elaborating on a couple different examples of the different natures of the consult. So an individual staff concern versus a patient concern.
Yeah, so let me think a little bit because I want to make sure I have some good examples. First of all, I just want to preface this that other than the first couple weeks of rolling out the program and rounding on the units with the nest coaches, I don't go on the units with them, and I don't have access to the private conversations that they have. So I can only give a couple of examples that I, know about in terms of just, kind of more broadly.
Sure.
I don't know the specifics because this is a highly confidential conversation that they have.
Yeah.
And I always tell the nest coaches, don't share your consults with me unless you're struggling with something that I can help you with, because I don't want anybody to ever feel like their confidences have been, broken.
Yes.
So, I think what I can say is, there could be situations in which, and I think more broadly, these weren't specific consults, but they could be potential consults, if you will. So for instance, there was, a situation in the NICU where a staff nurse had cared for a child that passed away. And then, when they came back in the next time, they were in the same bed space, taking care of another child who was, probably going to expire. So, just kind of that mental, relationship now of taking care of a dying child in the same bed space with, I think, the same issue could be something that a nurse was, just really struggling with.
Yeah.
Another potential one might be, we had COVID-19, and perhaps somebody has an elderly person living with them at home. And now they're, how do they best care for their patients and care for their person at home, their loved one at home? And that concern and worry about bringing something that could be potentially, deadly into their own home. So those kinds of situations might come up. It might be a staff nurse who is taking care of a dying child for the first time, and they're feeling very inadequate to provide that care because although they may have had experience in, while they were in orientation, maybe that was 6 months ago, and now they're faced with this for the first time. Or maybe just walking a patient down to the morgue, and just having some support around those things. Yeah. There are times where, we all want to help our colleague that's working next to us, but maybe we're so busy that we can't do that. So having somebody to call or consult with in those times, I think can be really helpful to staff nurses.
Yeah, absolutely. There was a question about when, well, first, thank you for the excellent presentation. Question was related to referrals. What reasons might the coach refer to their director?
So it might be a situation where they're either struggling with some communication or transparency around an interaction they may have had, whether it's a colleague, a peer, that they're bringing this to the nest coach because they just want to kind of talk it through and run it by somebody and, get their impression. What would you do in this situation? Or do you have any advice for me? Have you been in this situation before? And then, they, sometimes, and I find this very helpful in my own career, to be able to run something by somebody and talk it through. Sometimes you think about it in a different way afterwards. So then you might be better prepared, to go talk with your director or manager about it. Now you have the language and the words to bring with you when you go to that meeting, and you're feeling a little more prepared to have that conversation.
Great. Are the families and parents aware of the NEST program? Have you communicated that more widely?
No. So this is a service that is directly intended to benefit and support nurses. We don't want parents and families to feel awkward that a nurse is maybe struggling in any way, shape, or form. We want them to feel confident in the care that they're receiving. So we have not shared that with families. We do not approach, a staff nurse if there's family in the room, or, there's a patient that can certainly, understand what the conversation is. They are very, they're very, kind of, I'm trying to think of the word. They're careful, and they stay kind of away from the bedside and find the right moments to approach nurses.
Discreet.
Discreet. Thank you. Yes, they are discreet.
I was trying to think of the word too. I was like, well, maybe. As always, right, as good nurses, we're always concerned about budgeting. How did you pay for this? Where did that funding come from? Do you outline that maybe in your paper too?
Yeah, so this is one of the most popular questions I get on this. And as I said, we didn't get extra hours to, in any of the units to support the nest coach. That, through creative ways, our leadership was able to piece together across the units one FTE to support this team, because the rationale is that, we're already doing this. We just want to do it better, in a better way for our nurses.
Great. What about training time? So in addition to now kind of the functional time, the operational time, what about for training them? So did you budget for training time for that?
Well, we certainly, have had extra hours devoted towards training, but because this was supported right from the top, if you will, we were able to provide the necessary training.
That's great. That's great. What about other disciplines? Have you seen an interest in this from other disciplines?
Yes, we actually have, this is another really good question. So after we started the NEST team, one of our NEST coaches went down for a complex patient that was being transferred to another unit. And their team on that floor benefited from having the NEST coach do a team meeting. And they actually started their own NEST team for our hematology oncology and transplant unit areas. And they actually have a different name for it. It's called HEART. They have some other complementary services that they have implemented along with the NEST type role. And our physician colleagues actually reached out to us wanting to start their own team. And they have actually started it this year. And they make it available through the homepage of our hospital on the internet, and the doctors can make an appointment to speak with a colleague through that mechanism.
That's great. That's great. Judy just shared, a really rough situation. She said, I wish we'd had something like this on a day that one of our coworkers who was scheduled to work came into the ER and passed away an hour before.
Oh my
And we
goodness.
had to care for our babies and the loss of our coworkers in the same day. And now one person short, right? Talk about hard. Judy, we're so sorry that you had to deal with that. Would this be something, Michele, that the Nest team would have been able to
Absolutely. Yes, we actually received messages through the email from leadership saying, we have this situation going on in our unit. Can somebody from Nest make it a point to come around and spend some time with our staff? So absolutely, we would respond to something like that.
Yeah, it's really rough. And in those situations, it's not always quite that traumatic and dramatic, but there are often times, we work in big units with many staff and in different, phases of life, and accidents happen. And, those other things, our NICU families, right, are not the baby's families, but our family as colleagues, right? We're always having something, right? Especially, in our unit. I know a place I worked at just recently lost one of their assistant nurse managers, to COVID. And, it's one of those things where, you still have the work you came to do, but you're also grieving, the loss of one of your own. You're one of your own, right?
Right. One of the things we put in place at the beginning of this program, it was kind of an offshoot, if you will, of the Nest team and our efforts there, but it was part of the recommendations from the work group. We put into place a Paws after death guideline, because what we were finding is that our units have become so busy. There's just so little time for staff to just take a pause after the death of a child or a neonate. And, we wanted to make it part of the culture that staff felt comfortable taking that time for themselves to acknowledge the death of a patient. And we gave them in the guidelines, some guidance and direction around how to do that. And I think by doing that, it just kind of reinforced that, we're human beings and we need to be able to do these things, that, we need to stop and pause.
Yeah, I love that. I love that. How many of you have something like that? Do you guys have a policy like that to appreciate and to honor that moment, right? To give everyone involved that permission to do, like you said, to be human, to recognize that. I think that's such a powerful policy, right? Like an empowering policy. That's amazing. So I think that people are going to be reaching out to you about that too now.
Yeah.
To get that. Any other final questions? If not, we can kind of run through the CEU stuff so that you all can get your contact hours. But, just on behalf of Kathy, who had to jump, Kathy Bush had to leave a couple minutes early, but on behalf of her and the whole team at DandleLION, I'll say thank you, Michele, and thank you for your time and your, passion around this and many other topics that I know you're working on, and that we're excited to be able to share this. So let me bring up all my final notes that Kathy gave me, because I always want to do her proud.
I also want to just thank everybody for joining today and listening to our information about the Nest team. I do think it's so important for our nurses.
100%. Yeah, it's it really shows, right? It's, a lot of times we talk about clinical things on these webinars, but I think that this emotional support and that helping us to be the best at the job we do, these projects, these initiatives, and of course, this really amazing way that you've decided to investigate it and then to publish is important, because I think there are lots of these programs that are happening, and many people are just reinventing the wheel. And by providing the publication, you really are shortcutting and saving people time and money to be able to get to that result faster, and showing that it makes a difference. So that's awesome. All right, let me double check. Any final questions for Michele before I pop over to give you all the link and everything other things that you want? People are just saying thank you. Thank you very much. And lots of thank yous in there for you. So All right, let me quickly run through. As you know, these DandleLION webinars are awarded continuing education credits, and so you do have to complete the evaluation. At the end of this presentation, you will be redirected there when we close the webinar, so you can fill it out right away and you'll be emailed a certificate. It is for nursing CEs, but it may be reciprocal in other states. If you're watching this as a recording, just go back to the email, and on the resource page where you see the recording, you'll see the link to get your CEs and your evaluation. And just remember, you need to watch the entire part, like all the way to now, to get your credits, complete the online evaluation. If you are a group, then make sure that each person who's watching this as a group goes back and fills in the eval individually. So I will put a link in the chat area, but like I said, you'll get an email from us with another link in case you had to leave, or if for whatever reason your firewall might be blocking that. And just as a quick announcement, I know many of you know that some of the developmental products that we've all been using were discontinued and are back ordered right now. And so DandleLION Medical wants you to know that they are here to help you and that they are here to be with you to make switching easy. They have online videos. They have a private clinical, private consultation with one of their educators where you can actually go through those. They have many education series, instructional videos, and lots of national contracts so that you can get things, on demand and at the best prices. If you have not tried any of the products and you are worried about one of your products being discontinued, reach out to Kathy Bush directly, and she will make sure that she hooks you up with some samples, and then make sure you have all the evidence for making that as easy and seamless as possible. So don't be scared. Take this as an opportunity to try some new products, but just know that the DandleLION team is there and they're working on some exciting new things for you to help make this fill this gap for you as well. So I know Kathy wishes she could be here to give you this information herself, but I promise she definitely wants you to email her if you need any help at all. So again, I'll just say thanks to Michele for being with us. It's always a pleasure to see you and hear all of your amazing research. And thanks to all of you who are here and watching, and as well as watching the recording. Have a great day, everybody.